Hey everybody, welcome back to Pathology. Today we're going to go through lung tumors. So the lung tumors can be started by an infection. In particular, it's the cytomegalovirus. That's part of the torch syndrome. So the torch would be a group of infections that really negatively affect the developing fetus. And the T is going to be toxoplasmosis. The O could be like HIV and other bacteria that can cross the placenta. R is for rubella, C is for cytomegalovirus, and H is for herpes simplex. So they cause like the retinitis and pneumonia. Those are like one of the main infectious signs in adults, but in children it causes the cerebral calcification and the microcephaly, and then there would be developmental delays along with congenital cataracts, and it will show up as like the petechiae or purpura, but in particular the more dangerous signs are the hepatomegaly and the splenomegaly. An abscess can also be the trigger for a tumor formation, especially if it's a chronic abscess, usually caused by some kind of aspiration because stomach acid is acidic. It's going to eat through the lungs. And it can also be a complication of the necrotizing bacterial pneumonia. So it can cause a bronchial obstruction if it's in the bronchus, and then of course there's going to be a VQ mismatch because there's going to be no ventilation, but the perfusion is still okay. That's the ventilation perfusion mismatch. The septic embolism, of course, is problematic because it can travel down to the vein into the heart and then cause cardiomyopathy and carditis and pericarditis, all that stuff. And usually it's mixed because aspiration could leave an anaerobe bacteria, but it can also help the colonization of aerobic bacteria, so it's usually mixed. That's why they're very hard to treat. And the patient's going to cough, complain of pain, have foul-smelling purulent or sanguineous sputum. And in chronic diseases, it can cause the secondary amyloidosis because there's all that damage. There's going to be the laydown of the collagen. Okay, so tumors are usually separated into two: the small cell lung cancer or large cell lung cancer. Small cell is an indication of non-Hodgkin's lymphoma. Adenocarcinomas generally happen in the non-smokers. The non-Hodgkin's happens more in smokers. And the adenocarcinoma tumor cells are basophilic with necrosis. And in smoker patients, there's going to be the squamous metaplasia, which presents as these keratin pearls. Most of the tumors start in the hilar area, except for the adenocarcinomas. Those can just go anywhere. And in the adenocarcinomas, there's going to be a mucus or mucinous center, and they present as those signet rings. So it's like a ring with a little, a little flat top. Hamartomas are going to present as the popcorn calcification on the chest X-rays. Remember, hamartomas are going to be it's the normal tissue, but it's disorganized. Like the architecture is normal, but the tissue is supposed to be there. The other one, the choristoma, is going to be normal architecture, but that's not the type of tissue that's supposed to be there. Like the Merkel's diverticulum, it's pancreatic tissue in the intestines. Carcinoma in situ is the stage before the invasive squamous cell carcinoma. So in situ, they grow along the alveoli and they grow along the septa, but the basement membrane is intact. That's the important thing you have to remember. The bronchiolo-alveolar carcinoma, is going to grow along the pre-existing septa without the invasion. So this is also another carcinoma in situ. The large cell undifferentiated carcinoma And it's going to be like a mess of cells. You can't really tell whether they're squamous, cuboidal, or columnar. Continuing on, they present as fever, cough, or they can be symptomatic. The basement membrane intactness is going to be the precursor, and the cuboidal cells are going to start to proliferate. A cavitation is going to be very common in the squamous cell bronchogenic carcinoma. Apudoma is going to be amine precursor uptake decarboxylase, and those are going to be very vasoactive amines, so they're going to be dilators. And those generally come from the neuroendocrine tumors. Those are going to present with a rash, diarrhea, cough, right heart, fibrosis, and it's linked to the cancer of the colon and the appendix. The cells in these are going to appear as these like spindly oat cells. And in the paraneoplastic syndrome, it's going to present with low sodium. Because it's a neuroendocrine tumor, it's going to affect both the lungs and the kidneys. Because remember, the kidneys and the lungs are connected via the ACE and the renin. So, going on with that kind of connection, in the paraneoplastic syndrome, there's going to be hypercalcemia and SIADH. And that could be due to the small cell carcinoma because of the, dissemination. And from there, it can lead to the Cushing syndrome, myasthenia syndrome, clubbing, hypertrophic pulmonary osteoarthropathy. So there's going to be the deposition of the complexes in the joints because it's an apud. So there's vasoactive amines. Amines are nitric acids, and then from there it can be turned into uric acid easily. They also present as a Trousseau sign. And they also have the lung lesions on the chest x-ray. Carcinoid syndrome is when carcinoid metastasis turns into the syndrome, and that produces too much serotonin. So with too much serotonin, there's always going to be these like allergic reactions. So flushing, diarrhea, along with the bronchoconstriction and the right-sided valve disease. So usually the carcinoid tumors start in the wall of the major bronchus, and then they push into the lumen. Carcinoid tumors have the neuroendocrine differentiation. Langerhans histiocytosis is going to be an eosinophilic granulomas, and they can be very disseminated into Hans-Schuller-Christian disease, or they can affect the very, very young. So those are the letter CO disease. In those diseases, there's going to be smooth muscle proliferation in the lungs, especially in the lymph angioleiomyomatosis. So in all of that, that's what they affect: the lymph, the vessels, and the uterus. So in general, they affect women, and they do respond pretty well to anti-estrogen, anti-progesterone, and oophorectomy. Silicosis is going to be a restrictive lung disease, and there are several different types. The intrinsic is going to be diffuse parenchymal, and those are generally the occupational and idiopathic fibrosis. The interstitial lung disease is going to usually be caused by eosinophilic materials that fill the alveoli. And the silicotic nodules are going to contain quartz, asbestos, and these dust cells, which are macrophages. Those generally affect the lung apex and the upper lobes. Emphysema is going to be the complication, and cor pulmonale. And unlike the co-worker pneumoconiosis, this one has a risk of tuberculosis and lung cancer. It appears as these eggshell calcification of the nodes. Why is it carcinogenic? It's because silicon is carcinogenic, along with asbestos and whatnot. Okay, abbestosis is also another interstitial lung disease, which is restrictive, and it's going to present as diffuse pulmonary fibrosis. So in these cells, they are called ferruginous bodies because the asbestos fibers are going to be coated with protein and ferritin. They're gonna look like the dumbbells, and they affect the lower lobes, while in silicosis it affects the upper lobes. Mesothelioma is, of course, the progression of asbestosis. Most commonly, it presents with these, pleural plaques, and they are the laydown of both, fibrin and calcium. So they do calcify over time. There are some different types. We're not really going to go through this now, but like epitheliosarcomatoid and mixed types. The mesothelioma, of course, spreads either mostly really to the peritoneum, the pleura, the pericardium, and the tunica vaginalis in men. If you smoke cigarettes, the risk of lung cancer increases like 60 times if you have asbestos exposure. Small cell lung cancers are going to present as these little nests of these polygonal cells, and they also have this feature called nuclear molding. In pulmonary adenocarcinoma, there's going to be very small, short, plump microvilli, while in mesothelioma, they have long and slender microvilli. Pneumothorax, the most common cause is either Marfan's, which is spontaneous, or Pseudomonas infection, an aspergillosis infection, or traumatic injury. HPV is going to cause the nasal pharyngeal carcinoma, which whenever Epstein-Barr virus is present. Don't know why, but it generally is more in people of Chinese descent, like the ones that actually form the nasopharyngeal carcinoma. Oropharyngeal carcinoma generally is in homosexual men or women, generally men though, if they perform oral sex, because the HPV can infect the squamous cells in the throat. So HPV, the important strains to know is 16 and 18. These are the most common malignant cells. I mean, there's 31, 33, and 45, but 16 and 18 are the most common ones. 6 and 11, however, is benign. Of course, you're going to look for the coilocytes on the pap smear. We've already gone through that. They're the halocytes. Laryngeal cancer is going to be either the non-malignant vocal cord nodules that occur due to overuse. So people who are professional singers, people who are radio broadcasters, anybody who uses their voice a lot, or people who have been infected with HPV. But carcinoma of the larynx is really, really rare. And they present with usually just persistent hoarseness, but that can also be due to a laryngeal nerve lesion. So something that you have to pay attention to. So that's it for now. Thank you for your attention and good luck studying.